Hello and welcome to the channel. So today we are going to discuss one learning case. So our patient is 79-year-old female with history of lower abdominal pain for the past 2 months. More concerningly, she also reports vaginal bleeding occurring 2 months prior to the presentation. And postmenopausal bleeding is never normal and always require investigation, right? She attained menopause 30 years ago, has history of 7 pregnancies and reports white vaginal discharge and some perianal itching. On examination, a bulky cervix was noted. This clinical context immediately raises our suspicion for significant pathology and mandates through imaging evaluation. Then we did ultrasound and look over here, the uterus is anteverted, appears bulky, and look over the endometrium, which is markedly thickened, measuring approximately 3.5 cm in maximal anteroposterior diameter and appears heterogeneously iso to hypoechoic. There are few small cystic spaces noted within, and endomyometrial junction is well defined throughout the majority of the uterus. However, the junctional zone in the posterior aspect demonstrate ill-defined margins, raising suspicion for adenomyosis or any significant pathology like early invasion or malignancy. So in the same patient, we did color Doppler imaging, and here we can see that there is a increased internal vascularity within the endometrium. So based on the ultrasound findings, our impression was mildly thickened endometrium suggestive of endometrial hyperplasia, and the ill-defined endometrial junction in the posterior superior aspect requires further evaluation to exclude other pathologies. So we did MRI for the same patient, and look over here, this is the T2 sagittal image demonstrate the uterus in the midline. The myometrium appears homogeneous and is unremarkable but thinned out. And look over here, the endometrium is markedly thickened, measuring approximately 3.5 cm in maximum anterior posterior diameter. The endometrial signal intensity is heterogeneous, demonstrating predominantly hyperintensity relative to the myometrium. There are small, well-defined cystic spaces are identified within the endometrium, involving diffusely throughout the endometrium. The endomyometrial junction visualized and appears intact. And in the axial T1 images, the myometrium again it is homogeneous and normal in signal intensity. The endometrium demonstrate relatively uniform iso intensity compared to the adjacent myometrium. The cystic spaces seen on T2 weighted images appears hypointense in the T1 weighted images. The endomyometrial junction again it is visualized and intact, well defined. So in the contrast weighted images, the endometrium demonstrate heterogeneous enhancement. The cystic components seen on T2 weighted images do not enhance, consistent with fluid filled spaces. Notably, there is a early subendometrial enhancement. In the corresponding subtraction images, the subtraction images highlights the enhancing portion of the endometrium, making the non-enhancing cystic spaces are more conspicuous. So in the diffusion weighted images and the corresponding apparent diffusion coefficient map demonstrate no evidence of restriction diffusion within the endometrium. This finding is reassuring and makes high-grade cancer less likely. Look over here, dynamic contrast enhanced MRI reveals early and persistent enhancement pattern of endometrium as compared to the myometrium. The time intensity curve, look over here, show rapid initial rise followed by plateau phase. This pattern is consistent with the hypervascularity associated with the endometrial hyperplasia. In screening, there is no evidence of any significant pelvic lymphadenopathy or para-aortic lymphadenopathy or any significant findings in the abdomen. Then the MRI findings in conjunction with the patient's clinical presentation and initial ultrasound are most suggestive of benign endometrial hyperplasia. So the MRI is valuable in characterizing the endometrium when ultrasound findings are equivocal or when further evaluation is warranted. The presence of well-defined endomyometrial junction on MRI is a key feature in differentiating benign endometrial process from invasive disease. Diffusion weighted images can be helpful in risk stratifying patients with endomyometrial thickening. So benign endometrial hyperplasia is an abnormal proliferation of endometrial stroma and glands and represent a spectrum of endometrial changes ranging from glandular atypia to frank neoplasia. Up to one-third of endometrial carcinoma is believed to be preceded by hyperplasia. Transvaginal ultrasonography is the first-line imaging modality for evaluation of the endometrium. Postmenopausal patients who present with vaginal bleeding should undergo transvaginal ultrasound. With The thickness of endometrial layer should be more than 5 mm in postmenopausal women not receiving hormone replacement therapy, or more than 8 mm in patient receiving hormone replacement therapy or tamoxifen therapy. According to the 2024 WHO system classification, endometrial hyperplasia classified as endometrial hyperplasia without atypia or atypical hyperplasia or endometrioid intraepithelial neoplasia. Endometrial hyperplasia diagnosis is important due to the higher risk of developing endometrial carcinoma. It is generally accepted that in symptomatic postmenopausal female, an ET of more than 4 mm is considered abnormal and requires a biopsy. So this is all about the endometrial hyperplasia. Thanks for watching this video and stay tuned for the next one.